Thank you for joining us today. My name is Annie Prasad, and I am the Product Marketing Manager at Springer Publishing. Today, we are presenting Depression and Anxiety in Older Adults, Recognizing and Addressing Mental Health Concerns with Dr. Erin Woodhead, Professor in Department of Psychology at San Jose State University. She is a licensed psychologist and holds a PhD in clinical psychology from West Virginia University. Dr. Woodhead's research interests are the areas of substance use and treatment utilization in adulthood, particularly among older adults and mental health in midlife and older adulthood. Before we begin, a quick reminder, this webinar is being recorded and will be available on demand at springerpub.com/videos in 5 to 7 days post live event. If you have any questions, please type them into the QA box on your Zoom control panel. I'll bring them up at the end of the presentation. If you forget to ask a question, there will be a brief survey sent at the end of the webinar, and you can include your question there. Now, let's get started. I'll turn the presentation over to Dr. Woodhead.
Hi, everyone. Thanks for joining us today. I'm always excited to see a big group at these topics related to aging. I've been working in the area of aging for the past 20 years or so and have seen a big increase in folks interested in this area. So I'm glad to be here today. So let me outline what we're going to cover today. When we think about mental health and aging, one of the things we really want to think through is how older adults present differently and have unique needs compared to other age groups. And so today I'm going to focus on depression and anxiety. And in our discussion around depression, we'll touch on the topic of suicidality, because that's something that as providers and as we're training folks to be in this field in the area of mental health, we really want to have that top of mind as folks are working in this area. When we get into anxiety, one of the things that often comes up is there's a huge overlap with sort of distinguishing anxiety from other physical health conditions in older adulthood that can look a lot like anxiety and have overlap of symptoms. So that's what we'll focus on when we get to anxiety. And I also want to touch a little bit on fear of falling in the anxiety piece, because we see that come up quite a bit in this population. So let's start with a case study that we'll revisit. So as a psychologist, I'm always interested in how people are thinking about aging and some of, kind of the cognitions and the thoughts that they have around getting older. So here's an example of a case where we tend to see some cognitions and some maybe unhelpful thoughts around aging. So we have Mrs. Rogers, 67, referred by her physician due to chronic depression and hopelessness. And she states her main problems are to do with her age and that it's likely to get worse as she gets older. So Mrs. Rogers reports to the provider that aging is a terrible experience for her and says there's not a lot of joy in life once age sets in. When she's asked about her daily activities, she reports that she does a lot of sitting and not a lot of doing. And when I do go out, I can't be bothered and wish I were back home. And so this is one profile. There's lots of profiles of what depression can look like among older adults. This is one profile that I'm going to spend a little bit of time on today that really emphasizes how aging can kind of be used as the reason why people aren't feeling like themselves, as opposed to recognizing that there's an underlying mental health problem happening. So one of my areas of background is development across the lifespan. And so I always like to really understand a developmental view of what's happening with mental health, because when we're working with an older person, we need to consider what things have looked like over the course of their life. So is the depression, for example, with Mrs. Rogers, is it a sort of a lifelong problem that's come and gone as she's gone through different stressors? And we're going to talk about these distinctions in today's presentation. Or is it kind of a late onset, that started as she got older? And so what we tend to see is that overall, older adults have less kind of negative mood and less negative affect and symptoms of depression compared to younger people. And so this is part of the reason why mental health and aging has been, sort of largely ignored for a long period of time because a lot of times some of the main mental health problems that we think of are sort of associated with younger adulthood. High emotionality, high sadness. Even when we talk about substance use, we kind of think of that as a younger person problem. And so what we see here, though, is that it is true. Like the good news, right, of aging is that it is true that you do develop better coping strategies. You're better able to sort through sort of what's important to spend time on and what is not important to dwell on in terms of what affects your mood. And so we do see a decrease in depression. But then, as we note here in this graph, we see this sort of uptick in late life. And so now that we are living longer, healthier lives, we really start to see, you can kind of see this uptick around age 80 when folks are starting to have maybe more impact of health problems set in. Their mobility may be more limited. And so once we get into this range, we start to see an uptick again. The other thing we want to attend to is that there is a gendered experience of depression in particular throughout the lifespan, that women tend to have higher rates of depression at all ages, except as we head into, again, this period of late life. And what we see happening here is that we see that nice trend that we talked about of like things kind of going down, getting better with age, and then this uptick in late life. And what we see driving this closing the gap in late life is that the depression rates of older men are coming up to meet the women. And so this is one area that we want to focus on today, that there are differential experiences of older men versus older women when it comes to depression, and that we have, a particular interest in paying attention to older men as they, especially as they maybe lose important people in their lives, and how that can impact their experience of depression and other mental health conditions. So let's kind of review what we see. So in we looking kind of internationally using just a screener. This is not, a DSM diagnosis, but we see, more than a quarter of older adults worldwide were screening positive for depression. And we are concerned about it because it definitely impacts quality of life, in terms of day-to-day activities. But we also see that folks, older adults who have depression, are showing up at their physician more often. They're having more difficulties with managing their chronic medical conditions. They have higher mortality rates, potentially related to managing those chronic medical conditions. And they have higher rates of suicide, death by suicide. And that's something that we will talk about today. What can be particularly challenging is that older adults often attribute their mood symptoms to aging rather than depression. And so you hear people talk about, old age has just been really hard for them. They're too old to change things now. And so what we then see is that the problems that they're having are viewed as being kind of an internal problem, that they are not coping with aging well, that it's affecting everything in their life, and that it's probably not going to get better. And we know in the mental health field that when we have these kind of attributions that are internal, they're global, they're stable, like those can be very hard to shift, those attributions. And so part of what we need to focus on is a recognition that it's not about the aging, it's about having the layer of a mental health condition on top of the aging. And that if we treat the depression or whatever condition is kind of adding to the difficulty, then the person will likely feel like they're able to cope with the aging process a little better. But that can be difficult for providers because it can feel like occasionally the presentation is an older person who kind of sort of has like a laundry list of problems related to aging. I'm not sleeping, I can't get my diabetes under control, and this is all due to aging. And so it can feel like it's really hard to create some momentum for change in those areas. One area to highlight as we work with older adults is that they are more likely to kind of have a sub threshold or sort of subclinical depression compared to younger people. And so we kind of have this idea that as we get older, we saw that slide, right? That many mental health problems decline in late life. So we do see lower rates of depressive disorders, anxiety disorders, these kind of more severe conditions in late life. The only areas where right now we see kind of increasing or being more prevalent, definitely people are talking more about alcohol and substance use among older adults. And that is going up now rather than kind of declining in late life. And then we also see neurocognitive disorders, which makes sense, but also hoarding and sleep problems as more prevalent or more severe among older people than younger people. So, for the most part, the majority of mental health conditions decline with age. But with this idea of subthreshold depression, we see that a lot of older people are not being captured with a depression diagnosis because they are kind of in that subclinical range. And what that means is that they may only have a few symptoms of depression, and it's not enough, right, to trigger the diagnosis, to trigger the treatment and the further follow up. One example where this comes out is that many older people do not endorse sadness as a symptom of depression in terms of kind of negative affect, right? They're much more likely to endorse the anhedonia symptom, the lack of interest in doing activities. And so we may not hear the sadness. And that is something that providers are trying to tune into. They're listening for, right? Is there any sense of feeling down or depressed? And that may not be the presenting problem. It may be an older person saying, yeah, I kind of stopped volunteering with that group a while ago because it just wasn't a good fit anymore. Or I haven't been seeing my friends as often because I haven't been able to find time to meet up with them. And so as providers, we may just think of that as situational. Oh, okay, so maybe something situational happened. They're not able to do these things anymore. But really, that is the main symptom of depression that we're looking for. So as we think about making the diagnosis, right, we have either the low mood or the anhedonia, and we orient more towards the mood and less towards the anhedonia that older adults are more likely to present with. What this means for providers in the community is that compared to other age groups, older adults are are less likely to sort of front with depression in a way of being very open about being sad and down. And so they may talk about the anhedonia that I mentioned in the previous slide. They may say, my memory hasn't been as good lately. I haven't been able to concentrate when I'm trying to read a book. I haven't been able to follow and concentrate on what's going on. My sleep is changing. I just don't have the same energy as before, right? It's harder for me to make decisions. And so that's not the typical, well, that's not what providers are sort of trained to tune into for depression. And so they end up going down the path of, oh, maybe there's a cognitive problem happening, right? Or maybe there's a health problem happening. And it's also compounded by sort of a little bit of ageism that can come through where we sort of expect older adults to have low energy. And so we may not follow up on that concern, right? And we all have those biases that we need to monitor. And we want to be clear that we don't we don't want to associate aging with being sad and lonely, right? Or not being interested in doing things. So when we are faced with somebody who's describing symptoms in this way, not really upfront in describing kind of sadness, it it goes off in a different direction most of the time in terms of assessment and treatment, right? So that can be kind of a tricky part for providers to pick up on. As I mentioned previously, we also want to attend to the early onset versus late onset of depression. So we have folks who have had mental health problems most of their life, and now they're aging. And so that may present a new stressor in their coping strategies that they had are no longer kind of working in this environment where they're aging and managing health problems. And then we have late onset depression, where the person couldn't really identify having any one, diagnosed period of a mental health condition any other time in their life. And now they're 60 or 65 and they're reporting these mood problems. And so these are actually different profiles that I'm working with somebody who's had a long-standing depression and is now aging. It feels pretty different than working with somebody who has a new onset depression in older adulthood. The new onset depression in older adulthood, can be related to loss, transitions that the person's going through, retirement, for example, new health problems, or managing health problems in a different way, where they feel like their routines are kind of off, and that sets them up for kind of pulling back from things and withdrawing and avoiding things a little bit. So this distinction, right? It's always good to tell me about what this has looked like for you in adulthood. What did this look like for you in younger adulthood, in middle adulthood, and how does it feel different now? It's always something that we want to kind of know the full experience of these problems that they've had throughout life. What else do we see with depression in older adults? A lot of chronic medical conditions, and so this is kind of bi-directional, right? So if depression is untreated, it can make it harder for people to follow their treatment plans and consistently even adhere to medications and this sort of thing. If their health is difficult to manage and they're struggling with adhering to their treatment plan for their health condition, that can then further their depression symptoms. So we see that the health and mental health kind of have that bi-directional relationship, especially as people age and are more likely to have chronic medical conditions. Anxiety and insomnia, we often hear those going together with depression. And in particular, when we hear a lot of sleep problems, we want to tune into that because that can be associated with kind of a more severe course of depression. And it can also impact cognitive functioning a little bit more. The tricky thing with sorting out cognitive functioning and depression with older adults is that when people are depressed, they kind of show a difficulty with attention, maybe lack of initiative around things. And when somebody's having some cognitive changes, they can show those same things. So, often a question that comes to psychologists is this depression or dementia? How do we sort through this, right? The good news is that with insomnia, there are some very specific kind of sleep hygiene techniques we can do with older adults to help at least get back on track a little bit with sleep. Let's move into talking about suicide in late life. So, when we think about, again, over the lifespan, we see that for women, there's actually kind of a peak suicide rate in midlife, sort of before people get to older adulthood. And then for men, we see the peak in late life. And in particular, we have targeted this group of older white men over the age of 85 living in rural communities that are at very high risk for suicide. Often this group has access to firearms, for example, and they are often widowed. And so there's a high degree of disconnection and loneliness from family and the different relationships that maybe their partner kept them connected to. Here we can again, again, it's sort of a gendered experience here. You can see the distinction. So this is looking at older adults starting at age 55. We have kind of the young, old group of older adults. Then we have our 65-year-olds to 74 and kind of going up to the 85 plus in the different colors here. And then we have kind of over time how these suicide rates are changing. And so we do see this slight in the green for the women, this slight kind of steady rise in the 55 to 64-year-old group. And so we are monitoring that. But you can see the reason why we're really attending to older men is this kind of alarming increase that we see compared to women. I mean, really, women stay fairly connected, and they have a lot of protective factors in place, social, medical, a lot of times because they've had kind of consistent, especially if they've had children, they've had these kind of consistent touch points with the medical system to receive health care. Men maybe are less likely to have gotten some of that preventive health care. And then we see it compounded with maybe widowhood, right? And so this blue line up here with the graph reflecting male suicide rates is what I'm emphasizing. The 85 plus demographic of men is one that we really want to be aware of. So what we see happening is, again, when we look at just suicidal ideation, we see that it goes down with age, right? Younger people are, again, the most likely to kind of report suicidal ideation. They have more attempts, higher attempts to completion, right? What we see happening with aging is that the ideation is not as high, but the intent is very high, and the lethality increases with age. And so there's fewer kind of warning signs, there's fewer attempts overall. And so the ratio, they may attempt once, right, and complete suicide, whereas a younger person has many attempts in relation to completion. So what we are wanting to be aware of is that some prior research found that most older men who committed suicide had seen a primary care doctor within the past month. So these folks are not disconnected from medical care. It's that they're not presenting with suicidal thoughts. They're not talking about it, but they have an intent to do it, and they are doing it in a very lethal way. And so that's why we want to be very direct in asking about suicide, to not shy away from asking about that with older people. What puts people at risk? Definitely chronic pain, um, recent life events. We know depression can put people at risk, and we want to attend to cognitive changes. So I put this recent article here as kind of a highlight of one of the risk factors that we see that suicide risk may be higher during the early stages of Alzheimer's disease and other dementias. So when people are first diagnosed, oftentimes they're at a mild to moderate level of cognitive impairment, and they are aware that they're going to be losing some of their cognitive abilities as they go forward. And at the same time, they have enough cognitive abilities now to plan and execute a suicide, right? Which is usually not the case when people have dementia at a fairly severe level. So when we look at kind of suicide rates, we see that suicide deaths within the first year of newly diagnosed dementia was about 53% higher when compared to suicide rates in the general population of older adults. And again, we see that it's more lethal We have mostly firearms being used in this situation. And so we want to really be aware. For example, in this graph, we see that among men who are receiving, these are all men who are receiving a diagnosis of some type of dementia. I'm sorry, this also includes women. So we have men in the top dashed lines, women below, all are receiving a diagnosis of dementia. And we're looking at the probability of completed suicide. And we see that men who have received a diagnosis of dementia up to a year out are at a higher risk of suicide. And so, we want to be screening when we know that somebody has gotten this new diagnosis. We want to be talking with them, touching base, because there is a big impact on mood and how they see themselves changing in the future. So before we move on to anxiety, I want to touch base about psychotherapy with older adults with depression. The good news is that older adults benefit from psychotherapy. It is as effective as it is with younger people. There previously was some belief that maybe older adults wouldn't benefit from therapy because maybe they're more reluctant to make changes or they're less interested in making changes. And we really see that, that's not the case. Older adults, of course, everybody has different levels of motivation, but in general, older people are, respond to treatment. The other good news is that we have a lot of treatments that are, shown to work with older adults. And so I just did a brief kind of summary here, that we know that cognitive behavioral therapy has a lot of support for late life depression, and it focuses a lot on some of those negative beliefs about aging, and then the tendency to kind of pull back and withdraw from activities. And so we're trying to create some shifts in how older adults think about aging and think about their mood, and then re-engage them with their activities. The same for behavioral therapy. We can do a lot with behavioral activation. I've actually found in working with older adults with depression that a lot of times they are more interested in kind of the active behavioral approach, and they're less interested in some of the more cognitive focus. And I don't think that's because, you know, there some people said, well, maybe they're struggling cognitively and they can't really do the different components of cognitive therapy. I don't see that as a problem. I see that there's a desire among older adults to really learn active techniques, to something they can do and put into place to manage depression. So, a lot of behavioral activation components can be really effective here. We also have support for problem solving therapy, which is that these folks, especially when they have depression, may have a really difficult time kind of seeing solutions to problems. And we can teach distinct ways to approach problems and break them down into smaller, components that they can solve. We also see some support for reminiscence therapy, which is sort of a narrative approach where older adults are prompted to retell different phases of life that they've been through and how they see those phases of life kind of still connecting with the identity that they have as they're aging. And then interpersonal psychotherapy. This is one that I've used a lot with older adults. I find it really helpful. There's a great adaptation that's published for older adults. And the idea here is that depression results from kind of an interpersonal stressor or a transition. And so it may be grief, it may be a transition to retirement, it may be a conflict that an older adult is having with their adult children, for example, and that you work to treat kind of the interpersonal aspect of the depression, and that helps older adults kind of feel like they have a place to talk about those transitions and those interpersonal pieces that are changing for them as they get older. So lots of options out there, lots of resources available if you're looking for, has this treatment been adapted to older adults? The answer is yes, sometimes there is a specific adaptation for older adults that kind of accounts for, maybe slowing down a little bit, covering topics that are more relevant to older adults, for example, with all of these treatments. So let's move into talking about anxiety disorders. So we are seeing a relatively high prevalence of anxiety disorders among older adults. Again, we're going to see a higher prevalence among younger people than older people. We see about 7% of older adults over 65 meeting criteria for an anxiety disorder in the past year. And we also see that another reminder that not all older people are kind of the same in one group, that we see that anxiety disorders are a little bit higher in kind of what we call the young old group, 65 to 75 or so, compared to older groups. And then we see it a little bit lower in the age group before that, the 50-year-olds until they get to 65 or so. So we do see that there is a little bit of a peak in that 65 to 75 decade. And some ideas around that are that people are starting to more fully transition into older adulthood. They may have more health problems that start to come up for them that increase anxiety. They may be experiencing, they may have had a fall around their home and then be worried about kind of what that means for them, right? What are the most common? So definitely generalized anxiety disorder and specific phobias are the most common among older adults in terms of the umbrella of anxiety disorders. Oftentimes in primary care settings, the most common diagnosis we see is anxiety disorder (NOS). And I think that sort of captures that sometimes providers aren't sure what to do about older adults with anxiety. It presents a complex clinical picture because it's sort of unclear, is this related to the health problems that they're having? Is this separate? Have they been sort of a worry their whole life? Is this now just increasing in late life, right? Under the umbrella of anxiety disorders, we actually see less social anxiety among older people. And some of that is sort of developmental, that older adults are kind of trimming. You start trimming your social network at some point as you age. And so you're also less concerned about kind of the minutia of social interaction, less kind of caught up in some of that, those interaction components, right, that we know can happen in a evaluative way with social anxiety disorder. When we look at, again, a lifespan approach to thinking about these conditions, a lot of times people develop anxiety disorders in young adulthood, right? It's uncommon for people to have a new onset anxiety disorder in older adulthood. So unlike depression, with depression, we do see it's relatively common to have a new onset depression in older adulthood. It's less common to have that with anxiety. And so then what we're seeing as providers is, now this is somebody who's had long-term anxiety. Now they're aging. Now they have medical concerns, and it's all kind of coming together in one picture, right? Maybe the anxiety is now heightened. And I've heard this, from a lot of providers, is that, the anxiety was there. Family members will sort of describe, yeah, they've always been a little bit of a worrier. But it felt pretty manageable, when they were an adult and they were working and had these different, aspects to their everyday lives. And then from family members, we'll hear that once, they were diagnosed with this condition, or once their spouse passed, it really skyrocketed their anxiety. And now, they worry about everything. And so then adult children are getting, phone calls during the day. Something's wrong with my TV. I can't figure it out. I'm really nervous that this means XYZ. Can you come over today? Can you fix it? A really, really perseverate on things. And adult children and providers are often unsure how to respond to that. What we see happening then is that it's hard to distinguish between, right, this idea that we all have a little bit of anxiety, and having a little bit of anxiety is usually good for us. It's when it really increases and impacts our functioning, that we start to be worried that this is now kind of a clinical level of anxiety. And so what tends to happen is that providers have a hard time kind of distinguishing between, well, if you have a lot of chronic health conditions, it's probably good to worry about that a little bit, right? And when does that cross over into being not helpful and having a wide impact on the person's life? So what we see is that both older people and providers kind of view anxiety and avoidance as kind of a normal part of aging, like kind of a retreating from things, and that's they expect that with aging. And so that becomes a barrier to diagnosis. We also see that older adults tend to minimize symptoms, especially if you're just kind of asking, do you have this or not? Do you worry or not so much? Do you have difficulty leaving the house or not? So they can often not do well with responding in that sort of forced format. We also see that older adults use different language. They talk about concern. Well, I'm concerned about my health conditions. I'm concerned about your father's, um, you know, whatever it might be. And so they don't really talk about, I'm really worried about, you know, and instead it's framed differently in a way that people kind of think, oh, okay, yeah, you're concerned about it. That makes sense. And they don't recognize that, oh, actually, this concern is keeping them up at night. And they're not leaving the house because of this concern, right? They attribute their symptoms to physical illness. So that further like diminishes the chances that a provider will pick up on it. And, not related to necessarily like every older adult has difficulty remembering things, but there are times when they have difficulty remembering symptoms and reporting on them accurately, and that complicates the diagnosis. We look at one kind of factor that can be helpful to understand with providers is what is the content of people's worry? What are they worried about? And so, we see again in a lifespan view, the things that people worry about change as they go through different stages of life. And so they may experience symptoms differently as they have chronic health conditions. As we age, we have a typical change in some of our physical symptoms, like our sleep changes as we get older. And so that their experience of worry may be impacted and changed as they move into this different stage of life. So we also see that older adults worry more about health and disability. And they relatively, again, there's individual variability here, have fewer concerns about work. They may have transitioned out of that. Finances, there's large variability in that, and family. And so we sort of have this building up to a little bit of a stereotype that folks have in mind about older adults, that they're always talking about their health conditions. And there is some truth in that, because they that is top of mind. That's what they're worried about. If they're kind of verbalizing their running dialogue, they're talking about health. We also see that there are some very age specific fears that older adults have. And one of them is related to family, which is being a burden on people. And so we can see that there is a large kind of piece of wanting to avoid being a burden. There's also a cultural component to this, to what people worry about. And so I want to acknowledge, that in some cultures, it may be that they are very worried about family and their adult children and how their adult children are doing. And for sure, the burden on others has a cultural component of, really not, in certain cultures, really not wanting to be a burden and feeling like it'd be. I actually had worked with an older adult a while ago who identified as Japanese, and he said that he would rather die than be a burden on his family. And it turned out that his father had committed suicide when he felt like he was being too much of a burden to his family. So we have to be, aware of the cultural experience. Unfortunately, the research is not quite there yet with the intersection of age and culture on these diagnoses. We're just, really trying to focus on age as a unique experience. And now there's emerging more literature on the intersection of age and cultural identification, but it's still emerging in these areas. So what we run into then is a real difficulty in assessing anxiety among older adults. What is difficult is to distinguish between what's true anxiety and what is anxiety related to kind of other factors, right? So it may be that the person has a fear of falling, and maybe they've fallen before, and so they have a anxiety related to this fear of falling, and it's tied to the fact that they do have an increased risk of falling, let's say. The same thing might be you have an older adult with visual limitations. They may have anxiety secondary to those visual limitations. And what we have to figure out is there enough kind of avoidance and fear that this becomes its own separate anxiety condition. We also again see the concern about sort of subthreshold depression, I'm sorry, subthreshold anxiety, similar to subthreshold depression. And the idea here is that it may be in folks' best interest as providers to not adhere so rigidly to the DSM criteria when we're assessing anxiety and depression, because we just don't see that that really serves older adults. The DSM wasn't written with older adults in mind, is what we've concluded kind of in this research on particularly depression and anxiety. So I did want to highlight that there is a freely available protocol for treating worry in older adults. It's called Self-Help Stop Worry. It was developed by the VA. And if you Google for this, you can find it, a provider version and a client-facing version. And you can kind of see what the chapters are here. I put a screenshot where it kind of does a lot of education around anxiety. So this is available for folks to check out if you're seeing this in a lot of older adults. Before we wrap up, I wanted to address fear of falling. So fear of falling can develop into an agoraphobia diagnosis if it ends up resulting in a lot of avoidance, right? We see, what categorizes anxiety disorders is kind of this avoidant behavior, avoiding physical sensations, like in panic, avoiding leaving the house, avoiding certain situations and stimuli. So what we see with fear of falling in general is that it's more likely to be reported among older women, among people who have sensory impairments, among people who have mental health problems, and among those who are living alone with less social support, right? So when we sort of talk about treating fear of falling, we're talking about a cognitive process, but also some, balance training and helping people realize that they can do things, to help with their balance. And so a lot of collaboration with other disciplines when we're thinking about fear of falling. So what we see happening, right, is that they may have very pessimistic views about falling. They may have views about their balance, that they're unable to catch themselves if they were to trip. And we see that we can do a very nice kind of CBT protocol, introduce some cognitive restructuring, promote some goal setting, and we can see a nice reduction in fear of falling. Okay, thank you, everybody. I wanted to thank you for being here, and now we can open it up to the Q&A.
Yeah. Thank you, Dr. Woodhead, for an excellent, informative presentation. We'll go ahead and take some time for questions now. Just a reminder, please be sure to type your questions into the question box in your control panel. Okay, here we go. You mentioned strategies to use for sleep difficulties. Can you touch on that a little bit more?
Yeah, that's a great question. So I would point people to there is a CBT protocol for insomnia called CBTI. That is really helpful. There's some books available on this. And what we're trying to do, because we know that there's normal age-related shifts in sleep habits that people end up going to bed earlier and then having early morning awakenings, and then they end up napping during the day. And so, as a start, we would work on kind of cleaning up their sleep a little bit, making sure that they're being exposed to early morning light, which sort of sets their circadian rhythm going and can help with kind of managing the sleep throughout the day. If possible, the napping, we would want to work on that. And I know that that can be really difficult, but we might even try to time the napping so that they're not like napping late in the day, and then that impacts their ability to get to sleep and stay asleep.
Okay. How can we get older adults to better recognize anxiety as a problem?
Yeah, that's a great question. I think we want to understand what the trajectory has been, because we know that a lot of folks have had anxiety for most of their life and now they're aging with these chronic medical conditions. And so we really want to highlight for them by doing kind of a sensitive clinical interview that this may be a problem that they've had most of their life that has gone untreated, and it may explain a lot about some of the worries that they're having now. So, as much as we can really highlight that it's likely the case that this has been a long-standing problem, and now we know about it, we can provide some solutions for it.
Okay. Is late onset or early onset depression more common among older adults? What factors can trigger late onset depression?
Yeah. So what we see, it's actually, people are often surprised to learn that it's about 50% each way. So when we see older adults with depression, about 50% of them have had it most of their life, and it's kind of intermittent, comes and goes depending on life stressors. And about 50% are having new onset, late life depression, which can be tied to, loss and kind of grief that is happening in late life. It can be tied to, I got this new diagnosis. This is a lot of what happens. I have this new diagnosis of a health condition and I'm feeling overwhelmed, and I feel like I'm not myself because now I have this new diagnosis and I don't exactly know what the next steps are forward.
Okay. Any suggestions for talking with older adults about the impact of mental health and stress on physical symptoms, especially when it's a new idea for them? I have a client that have symphonic somatic issues,
Mhm.
but she can't quite believe that it could be stress and worry.
Yeah, this is so complicated with the physical and mental health overlap. I will say it's good to recognize that we're probably right now working with a generation of older adults that haven't had that connection between physical and mental health emphasized regularly, and so have really viewed it as two different things, or viewed it as like most mental health things don't really exist or can actually be explained by a physical health phenomenon, right? And so I'm always kind of trying to lead on a process of discovery, like let's look together at these timelines. Like, could there be some information that's collected in the course of a week, right? So that we can kind of see, oh, it looked like on these days, you had like maybe you were saying something like headaches, for example. It looks like you had more headaches on the days when you were feeling a little overwhelmed and stressed about things, right? And so we start to be like, do you think there could be a connection? Do you think these two things could be connected? And I know saying this, like providers are doing this and it's still really hard. And I think it's just really trying to pull it back to the theme of, do you think there could be a connection? Because what I'm noticing is that when you're telling me that, your arthritis is flaring up, I'm also hearing from you that you're having some, stressful conversations with your daughter those weeks. Just really trying to use specific examples to pull that theme out for them.
Phys fear of falling. Have you seen any training to teach older adults how to fall in a safer way? An athletic trainer once mentioned roll up into a ball rather than stretch your arms out.
Yeah, yeah, I'll share that. I've heard that advice too, and my reaction has been kind of like, how are you supposed to think about that in the moment that you're falling? And so I think that what we do have is we have a lot of great like evidence-based balance training. And this isn't necessarily, it can be done through a physical therapist, and it's great to have other providers that you can collaborate with. But also, there's protocols that are Tai Chi related that are focused on improving balance and stability. And the idea that, like, some people kind of have this idea that I'm clumsy and it's just like an aspect of my personality, right? And we want to really emphasize that it is the case that we can train these things and these things can change and improve. Um, we do have like we want to have some home strategies that folks have in place, like avoiding kind of throw rugs that can easily get caught as they're walking, having different supports in the bathroom for showering, for example. So I would go with that type of intervention before kind of thinking about that sort of falling strategy. I mean, I think those things are certainly true, but I would want to back us up a little bit to the prevention aspects as well.
I am currently working with a 60-year-old Caucasian female with COVID-induced dementia. Are there any
Mm.
studies with treatments for depression within this demographic?
Right. So we do have, I will say, we do have a great scale for assessing depression and dementia called the Cornell scale for depression in dementia, that emphasizes the input of providers, for example, that can observe behavior. We do see that we can successfully treat depression in dementia. We have to focus more on the behavioral side of things, of sort of activating the person, maybe try to get a family member involved who can provide that support of carrying through on the recommendations at home in between sessions. And then we do need to really slow down and emphasize, for example, in a session, is there kind of one thing that you want to emphasize in this session? Could there be some index cards that the person takes home that serve as reminders of this one thing? So really breaking things down more distinctly, involving a family member. But there are definite treatment modifications that we can make to try to reduce some of those depression symptoms in dementia.
How effective are medications for treatment of depression and anxiety with older adults?
What I've noticed is that older adults are not as interested in medication because they're already on so many medications that they feel like they don't want to have an additional medication that can have side effects. And so that's why older adults are sometimes actually more open to trying therapy because they recognize that the other alternative might be kind of managing a new medication and trying to figure out how the side effects are going to impact them. But that being said, there are some well documented effects of certain antidepressants. We would want to work with a psychiatrist or a prescriber who does routinely work with older adults because there are certain guidelines around kind of starting at a very low dose, and then sort of titrating up because we don't know exactly what their response will be. I will say that one thing that can happen if the provider isn't as familiar is they can start them at a very low dose and then they just keep them at a very low dose and then it never reaches an effective dose, which I mean it's better to start low and go slow is kind of the feeling with prescribing among older adults, but then we have to titrate them up to an effective dose. So there are some risks, but there are some good options if clients are interested in antidepressants.
Any specific interventions to use with those diagnosed with dementia, particularly with those ending their life at some point, as the best solution to avoid being burdened on a family?
Okay, so yeah, we are seeing more folks interested in talking about these end of life issues and maybe having a plan in place, right? And I think the biggest thing we want to be aware of there is that there isn't depression overlaying some of that decision making. And so I would of course, be very respectful of their decision making and be implementing, again, if it's somebody with dementia, a mostly behavioral activation focused treatment so that I can feel confident that their decision making isn't clouded by an overlay of depression on top of the dementia and the plans that they have around end of life care. So I would really focus on um, protocols around behavioral activation to get them connected to things so that it's not a picture of kind of just withdrawal and avoidance around some of those concerns.
Hearing issues are associated with dementia. Is there evidence that hearing issues are associated with depression or anxiety? Do you have recent resources for this?
We are seeing more research in this area. I don't have resources top of mind right now, but would be happy to follow up with some information on this. So the concern broadly is that hearing loss can lead to a disconnection from the environment. And so it's essentially serving as a withdrawal from the environment because with the hearing loss, older adults aren't able to engage as much as they would. And so they sort of sit back and let things happen. And then they're not, but as a byproduct of that, people don't then include them in the conversation and the decision making, right? And then the same thing can increase the risk of dementia because now they're kind of isolated. They're not as engaged as they were with the hearing loss. And that process can increase the risk of dementia down the line, right? So we do have some good adaptations for treatments for folks who have hearing loss. I'm not sure if we have something focused specifically on hearing loss, but again, we could focus on that kind of re-engagement and we could use our adaptation to work with a client who has hearing loss.
Any effective strategies on how to address depression in older adults who are in denial?
Yeah, I think again, we want to highlight it's interesting because I think this generation is particularly maybe um, less versed than we're going to see in future generations about mental health. So that may be part of the denial is that they didn't grow up with the language that we now have around this. And so as much as possible, as providers, we really try to understand and have empathy toward maybe it's not denial so much as they haven't really been exposed to this language and nobody's ever said to them, "Oh, have you ever thought about this?" Now, that being said, I know there are clients where it's been talked about very explicitly and they're still not willing to accept it, right? And if I had a good rapport with that client, I might be fairly direct in asking about is there something about this that's hard for you in hearing that there could be an aspect of mental health on top of, that explains a little bit of what you're experiencing? Is there something that, happened in the past, right? Maybe there's some negative experience they had in the past that kind of influences why they're not as open to having this discussion currently.
Okay, looks like we have two more questions.
Okay, great.
What resources are available for family and caregivers of patients with narcissistic personality disorder behaviors?
Yeah, that's a good question. I think we are seeing some increased recognition of some of those behavior patterns that maybe folks had accepted in a prior generation as a more well, that this person is just like this, and now we're seeing increased recognition of that. There are great caregiver support resources available. I don't know if they're targeted to folks with personality disorders, but for example, NAMI usually offers caregiver support to individuals who are caring for somebody with serious mental illness. And I've heard from clients that that can be a really helpful kind of community resource as an add-on to therapy where they can hear from and connect with peers who are also kind of in that caregiving role for somebody with a serious mental health condition. So I would try to look at what are the community supports we can put in place so this person has some peer-to-peer connection with other family caregivers around similar concerns.
Okay. Any recommendation for older adult with dementia and aggressiveness?
Yeah, this is so in my past right work, I've worked in long-term care facilities, and this comes up. I think what I like to do is to really observe what are the things that are happening in the environment before we see the aggressive behavior. So often, if we kind of do a little bit of a systematic observation, we used to do this in the facility where I worked. We sort of see that there are certain transition points in the day that increase the likelihood of aggression, or certain environmental changes, like when they first wake up or when they're first going to sleep, that increase the chances of the aggressive behavior happening. And so first, I want to just have a very clear understanding of what are the factors that influence the aggressive behavior. And then often, depending on the setting, you can work with the family, you can work with the treatment team. Like, could we try changing this just a little bit and see? Also, with patients with dementia, with aggression, I try to collaborate with the physician to make sure that any pain that they're having is being treated adequately, because we often see that pain is undertreated and that can result in aggression. And folks with dementia don't have any other way potentially to express that they're having this untreated pain.
It looks like we've covered all of our questions. Thank you,
Right.
everyone, for spending time with us today. And thank you again to our host, Dr. Erin Woodhead, for a great presentation. If you are interested in purchasing our presenter's book, Psychology of Aging, you will receive a 25% discount using code webinar25 at checkout on springerpub.com. As I mentioned, the recorded session will be available on springerpub.com in 5 to 7 days. Wishing everyone a great afternoon, and we look forward to you joining future Springer Publishing webinars. Bye for now.